Well, Sarah, thank you for that kind introduction. And first of all, kudos to you and your team for organizing this event. As much as I love the hybrid model of conference attendance, what a gorgeous venue to convene. I also appreciate Diego's relaxation techniques. I have a feeling I'm going to be using those next time I call an insurance company to argue a prior authorization for a treatment that my patients clearly need. But in all honesty, I've never been to a meeting like this one. And I thank you for recognizing that doctors, even medical oncologists, are human beings in need of renewal. And I say that because a couple years ago, and this actually explains sort of the whole purpose behind my tweeting, which may seem silly, I did a little bit of an exercise. So quite famously, if you type into Google a search string, it will actually start to complete the search string for you. And so to kind of get a sense, sort of take the temperature of the public opinion of oncologists, I typed in, oncologists are, and I let Google do the rest. And I have to tell you, this is horrifying and true. It said, oncologists are murderers. Oncologists are criminals. Oncologists are monsters. And when I step back and think about that, the people I work with, colleagues here, among the kindest people I've ever known. So how do we get this reputation, and how do we show ourselves to be more than chemo dispensing robots? And I think what's happened historically is I think we've been conflated with the indiscriminate toxicity of the treatments that we've given. And I came to this very personally. In the 1990s, my father received chemotherapy that sustained his life by a few years, but at tremendous cost. He had the baldness, he had the nausea and vomiting, he had no white blood cells, he was in the ICU with neutropenic sepsis. So I have seen personally that oncologists and the drugs we wield, we can be blunt instruments. But my reason in telling you all of this is that I think we're hearing today, and you're about to hear from me, that there's progress being made, and we are becoming more precise. And that's what I'm going to tell you about right now, is the diagnostics of ctDNA, circulating tumor DNA, and MRD, or minimal residual disease. Now, this conference is absolutely stacked with talent, and one question you should be asking yourself is, why is this guy talking to us about this topic? Why is a solid tumor oncologist wading into the waters of MRD? Specifically, why is a GI subspecialist doing this? And I'll tell you, my practice for the last 6 years, I've exclusively treated cancers of the gut. But before that, my fellowship was in hem-onc, and my practice out of fellowship also involved hematology. And so I saw, when I was doing heme, just the precision that we can achieve by measuring things in the bloodstream. So if you're dealing with a liquid malignancy, a leukemia, of course, the problem is going to be in the blood. But it turns out, and this is fascinating because this is a technology that should work across almost all solid tumors, we can now find the signal of those tumors in the circulation if we just look for it the right way. So what's happening here is you get this shedding, and sometimes it's actually we're inducing this. So through apoptosis or necrosis, the circulating tumor DNA, it gets released from the cancer cells themselves, and then we can measure it with, say, a blood assay. Now you'll note, we do have to separate the wheat from the chaff. There's signal and noise, there's some cell-free DNA in there as well, but we'll talk about ways we can get around that. As a GI oncologist, I have something of a blind spot when it comes to carcinoembryonic antigen, or CEA. It's the devil we know, and that maybe is a little bit too harsh, but what I mean by that is, it's the assay I was always taught to use to follow someone with colorectal cancer. It's readily available. I've never had to fight an insurance company on CEA, but it's always bothered me that it's such an imperfect assay. So there's two sort of test cases here. One is when the tumor is still in the body. So sometimes my colorectal surgeons will do a preoperative CEA. So what you're seeing there on the left, these are patients who we know have cancer in their body, and yet, even in the stage 3 setting, even when they're node positive, CEA is barely positive half the time. Whereas with ctDNA, we're seeing fidelity of about 90% or above in both the stage 2 and stage 3 settings. Similarly, our guidelines have traditionally allowed us, encouraged us to use serial CEA monitoring when we're watching for recurrence. But there again, you can see that CEA gets outperformed by ctDNA in detecting relapse. So every new technology, we sort of run the risk of being too seduced by its novelty. It's the same way that Apple sells us a new iPhone every year. It's the new shiny thing phenomenon. And we should be critical of these technologies and ask, well, what are the pluses and minuses? So I'll start with the disadvantages. Not all tumors shed ctDNA. The methodologies here are complex and, yes, expensive. One thing we have to think about is CHIP. So clonal hematopoiesis of indeterminate potential, that's some of that chaff, that's some of that noise that we need to subtract out if we're going to actually measure the ctDNA. And again, this is something that's new, and I know I keep referencing insurers. Not all insurance companies are going to allow us to order commercially available assays on our patients. And in fact, in fairness to them, we should be looking at the evidence-based. So as it turns out, this has been an absolutely banner year in colorectal cancer. I actually can't think of a year since maybe 2017 that changed my practice quite so much, and largely around diagnostics. So we owe a huge debt of gratitude to our Japanese colleagues. They have been running this massive, massive umbrella trial called Circulate Japan. And it has 3 components. The one that we know the most about so far is Galaxy, which we'll discuss in a minute. And Galaxy is purely observational, and of course that's going to come with its pluses and minuses. But there's 2 arms of treatment decision-making that come off of this. And so basically what our Japanese colleagues have been doing is measuring ctDNA in colorectal cancer patients 1 month after resection. And the 2 treatment arms, which I won't belabor because we haven't seen the full mature data yet. So one that's fascinating is post-op ctDNA negative, or VEGA. What they're doing there, which is bold, is randomizing those patients to traditional adjuvant chemo, but also de-escalation, where they are simply observed. And then the other trial, Altair, is basically the opposite, where the post-op ctDNA positives are getting randomized to traditional chemo, or traditional chemo sort of chased with, if you will, trifluridine tipiracil, which is maybe not an agent that all of us would have picked, but I think this will be a really interesting proof of principle. But let's talk about Galaxy. So this was presented at ASCO GI by Dr. Kataka and colleagues, and immediately set off a lot of conversation about whether this technology, as Dr. Siambar told us, is ready for prime time in the US. I've already told you about the background. Just to be clear, this is a bespoke tumor-informed, not tumor-uninformed assay. It's the Signatera assay. So the patient's tissue sample is paired to blood samples. And you can see that they're measured at these very fixed time points post-op. So in terms of the patients that they enrolled and then excluded, I think we have to follow the flow here. So they started off with about 1,500, and then they lost about 500. And it's always curious to see that kind of drop out. So about 300 of these patients actually got diverted to VEGA or Altair. About 100 didn't have specifically granular path staging, and another 100 just didn't get their 1-month post-op ctDNA draw. So that left us with about 1,000 patients. Now, the majority of those, thankfully, about 850, were ctDNA negative. The others who were ctDNA positive were followed, and they were called somewhat optimistically the clearance cohort, because one of the things that we're going to talk about, I think we finally have the biological proof of how and why adjuvant chemotherapy works. And I think that's really exciting. So sometimes at these conferences, you see a little bit of statistical skullduggery. People play around with the y-axis, or someone tries to squeeze a laser pointer between 2 curves. These curves are way apart. You can drive a truck between them. And so what you can see is that the disease-free survival in all comers is almost 100%, or at least north of 90, if you're ctDNA negative, whereas if you're positive, we're seeing less than half 12-month disease-free survival. So that's a massive hazard ratio that, frankly, outperforms a lot of our traditional clinicopathologic criteria. If we really drill down and look at stage 2 and 3, the patients who we'd often be thinking about for adjuvant, again, you see this separation. Now the 12-month DFS is about 95% for the negatives, and a little bit over half for the positives. But again, a very impressive hazard ratio. So the dynamics are interesting. One of the things I'm taking away here is that just because you start positive doesn't mean you have to stay positive. And in fact, again, I think largely through adjuvant therapy, we can sterilize the bloodstream and see patients then achieve a better disease-free survival. So you'll notice here the reference group with 100% 6-month disease-free survival are the patients who started positive and then became negative. Now, you can argue that happened through some sort of endogenous clearance, like immunotherapy. We think that the T cells become aware of the cancer and can eradicate it as a native response. But I actually think that probably what's happening there is the benefit of chemo itself. However, the sort of counterpart to that is the patients who start positive and stay positive, they do the worse with a 58.3% 6-month DFS. Again, we're seeing here that by our traditional sort of staging and risk stratification, you can see the different benefits of chemotherapy. I think that the benefits here for both high-risk stage 2 and stage 3 are very comparable. And even the patients who are stage 4, so I think what's happening here is say, oligometastatic disease to the liver that's unresected, we've often struggled to know, should we actually be giving adjuvant chemo or pseudoadjuvant chemo in that setting or not? You may be aware that just last year, also from Japan, there was a trial that showed that whether you did hepatectomy or hepatectomy chased by FOLFOX, there didn't seem to be any difference in survival. But I think that's because we aggregate all these patients together. And I think if we use ctDNA technology, I think we'll get a better sense of who still needs that adjuvant or pseudoadjuvant treatment after their liver surgery. And then finally, again, this is, to me, the proof of adjuvant chemotherapy's benefit. Why should we be offering adjuvant? You can see that the rate of ctDNA clearance is not perfect, but it's a little bit more than 2/3. And there again, if the patients don't get adjuvant, there's still a chance that they'll clear, but it's small. It's 1 in 10. And so this really matters, I think, when we're counseling patients about whether to do adjuvant. I'm going to give you a real-world example briefly before I switch to the next study. I have a patient who had stage 3 colon cancer. She works with her hands, and she was absolutely terrified of the risk of neuropathy with oxaliplatin, and for good reason. However, when I measured her ctDNA, it was strongly, strongly positive. And I sat down with her, essentially giving her this data and said, listen, I really, really think that you need this chemo. And what was beautiful was not only did she then agree, and I sort of felt like we were authentically doing informed consent, I could then watch, I could quantify the clearance of that signal from her bloodstream. She's currently NED, and we were able to finish her oxaliplatin without her developing CIPN. So it's kind of the best of both worlds. I felt less like a blunt instrument and more like I was practicing precision medicine. So the other trial you've already heard about from my colleague from Vanderbilt, Dr. Ciambor, this morning, so I'm not going to belabor the repetition of some of the slides, although I think we have slightly different takes in a couple places. So stage 2 colon cancer, I'll just start by saying this is such a rich area of study because we've known now for decades from Mosaic and Quasar that there's this minority of the stage 2 patients who actually need adjuvant chemo. The majority of them, thankfully, are cured with surgery alone. And again, that's made it really hard to discern on a large scale how much we're actually helping. We have always known about these high-risk clinicopathologic features, and nothing actually makes me more nervous, for reasons I'll explain, than T4. Even then, we think the survival benefit is modest, maybe on the order of about 5%. So how do we balance this? How do we know that there's some patients who are going to do horribly, but most are going to do well? And how do we then determine who needs chemotherapy? So this, again, is really looking at the precision model. We've already talked about ctDNA. You've already seen this slide from Dr. Ciambor earlier. One of the things I want to point out, though, is that the 2-to-1 randomization is a tiny bit unfortunate because then we really have to be careful that we're not looking at relative proportion versus absolute risk and benefit. And again, I'll explain why I'm saying that. As she pointed out, this is a tumor-informed approach. And it's interesting, the 15 genes they picked sort of contain some of the usual suspects like APC, KRAS, BRAF, and RAS is in there. So I think this was a very interesting approach, but just to be clear, this is a technology that is not one that we would commercially order in the US. It is not Signatera as was used in Circulate. Okay, we've already seen this from her, but I just wanted to show you that the ctDNA approach is not perfect. So they did have a tiny signal here. This doesn't work necessarily for everybody. So some of the patients, but very few of them actually failed ctDNA analysis. So this is where I'm going to kind of flip my perspective on the trial. Yes, it is true that the relative proportion of patients who were ctDNA guided got less chemo. But the absolute amount of oxaliplatin goes up. So if you look at the numbers here, even accounting for the 2-to-1 sort of imbalance, the absolute number of patients who got oxali went up. Now you can argue that is not necessarily a bad thing. It's just that now we can discriminate who really needs that medicine. Because hand up, there is no drug that I give that weighs more on my conscience than oxaliplatin. You know, I referenced in another sort of banner year was 5 years ago, that was the IDEA trial. The IDEA trial immediately changed my practice. That's kind of my litmus test for, is this really a game changer? Is this worthy of all this other hyperbole? That one immediately made me sort of re-examine my whole practice. I went back from Chicago to where I work, and it allowed me to have the amount of oxaliplatin I was giving, and that cut by 2/3 the risk of permanent irreversible neuropathy for my patients, and that has allowed me to practice with a much better conscience. As she already mentioned, and I just went past it there, one of the things that might give us a little bit of pause on this study was the fact it took a little bit longer for the results to come back. Most of us would be more comfortable, I think, offering adjuvant within a 2-month window. I think 3 months is kind of pushing it. She's already showed you the RFS is overlapping. This whole notion about the width of the non-inferiority boundary is actually, I think appropriate to criticize if we're talking about such a small potential survival benefit. Should we have tightened up the interval? Regardless, I'm not a statistician. And then this is interesting too. So when you look at the subgroups, the T4 patients, again, they stand out as those that are most likely, I think, to benefit from a ctDNA-guided approach. And this again shows us that the positives are not necessarily condemned to recurrence, but certainly if you're positive and you're treated, you don't do quite as well as people that were negative and observed. So takeaways, and then I'm going to finish up by explaining my T4 consternation and then philosophize a little bit about adjuvant. So again, it is absolutely right to say that the proportion of patients who received adjuvant dropped with the ctDNA guidance. But again, I would point out that the absolute amount of oxali went up. And I think this is, again, sort of separating these patients into who is likely to benefit, but also who maybe doesn't need this chemo at all. So now when I sit down with a stage 2 patient, yes, we talk about the traditional T&M strata, but I am also going to be using ctDNA, and I already do actually, to guide those discussions. In the best case scenario, if you can work in tandem with your surgeons, you can actually have this information back by the time you meet the patient, which makes the whole discussion of adjuvant a lot less hypothetical. You do have to wait at least 2 weeks after surgery to draw something like Signatera, because otherwise you get a lot of debris, you get a lot of CF DNA from the sort of trauma, if you will, of the operation. But I found this incredibly worthwhile. So the reason T4 has made me nervous, this is an abstract from a couple years ago from a colleague, Dr. Kazi. And Sarah, you mentioned Twitter. If you don't follow Pashtun on Twitter, you're missing out. He is fantastic. He has long been an evangelist for ctDNA, and he's a master of the visual medium. So he uses emojis in the most professional way imaginable. I know it sounds weird, but if you check him out, you'll understand what I mean. So he presented this work a couple years ago, and again, I know these numbers are small, but what jumped out at me is that the positive MRD rate was triple in the T4N0 versus the T3N1 group. So again, I've often found this sort of worrying difference in how the high-risk stage 2 do versus the low-risk stage 3. And that nodal involvement may actually matter less prognostically than that T4 status. The other thing I thought was fascinating is, again, Pashtun was sort of showing us that the oligometastatic patients, they don't all maybe need adjuvant chemotherapy. And again, I've already belabored that point. So finally, I'm going to end with a little medical ethics and how this is all helping me feel better about the decisions that I make. So the trolley problem is sort of a classic quandary of ethical decision making. You have to weigh taking action versus passivity. So you're standing by a train track with this lever in your hand, and if you don't do anything, the trolley is going to flatten 5 people. If you pull the lever, the train diverts, and now you have to live with the knowledge that you intentionally killed 1 person. And I know this, you're like, where is he going with this? I'm going to use this as a paradigm also of how we decide to give adjuvant chemo, because I'll say that right now, if we're not being precise, I think that is the over-treatment. You know, if I took every patient with stage 2 colon cancer and gave them chemo, I know I'm over-treating the dramatic majority. However, we also can't risk under-treatment. If I don't give any stage 2 colon cancer patients chemotherapy, then I know, unfortunately, there are these bad actors biologically that are going to harm my patients. So this is how I think the field is evolving. I think we are becoming more precise and better doctors. So very quickly, some current or at least coming applications. One thing that's fascinating to think about is in the rectal cancer space, and I agree, the dostarlimab data at ASCO were unbelievable. What if we're actually moving away from TNT to TDT, total definitive therapy, those patients never requiring an operating room, never requiring a diverting ostomy? You know, if we saw a rectal cancer patient's ctDNA signal drop to 0 and stay there, would we feel more comfortable with watch and wait? I think the answer is yes. We've already talked about post-op assessment to guide chemo decisions. Just this week, actually, I used ctDNA. I had a woman in my clinic who had these lung nodules, and we were doing the assay to make sure that they weren't metastatic. As it turns out, it was an atypical mycobacterial infection and not lung mets. And it was actually this assay along with micro and palm that helped me figure that out. And then finally, as I said, the kinetics are amazing. So rather than just having a binary yes or no, when you quantify the ctDNA and see it exit the bloodstream with chemo, that to me is just so gratifying. Future directions, and again, Dr. Siambor mentioned this, and I think it's important that I do too. This is what I think is actually going to move the needle in America. So without sounding at all jingoistic in regard to the Japanese data, I think it's really important that we do trials domestically to make sure that this is truly generalizable and practical in a US population that might be a little bit more litigious. So NRG GI008 or Circulate US, what they're doing here is they're trying to aggregate about 2,000 patients, stage 2 and stage 3, do a Signatera assay post-op, and then you can see the bifurcation there to either the positives or the negatives. Just like in the Japanese study, in the negative group, there's going to be a randomization to active surveillance and no chemo, and that I think is absolutely fascinating. The other thing that fascinates me is if you look at the top arm, the MRD positives, there's going to be a randomization to chemo escalation, and that rather than FOLFOX is going to be FOLFOXIRI. And do we really need that triplet? We're going to find out. So with that, I'd like to close, and I just want to say again, without being too sanctimonious about it, when I first learned about adjuvant chemotherapy as a fellow, I couldn't really believe what I was hearing. You said, you want me to give chemotherapy, famously noxious drugs, to patients who have no evidence of cancer. And frankly, our surgeons, sometimes in an attempt to be reassuring, don't help us in our cause. So patients will sometimes come to me and say, Dr. Lewis, I don't know why I'm here, because my surgeon told me they got it all. That's the phrase that makes talking about chemo particularly difficult, even if it's right. So what I'm getting at is adjuvant chemo should be a hard sell. It should be a hard sell for our patients. It should be a hard sell for us. So knowing with greater precision who actually needs these treatments, I think that is such a huge leap forward, and there's no reason this technology shouldn't work beyond colorectal cancer and almost any other solid tumor that you can think of. And I think that's so exciting, and I'm just thrilled to share that process with you. So with that, I'll close, and I'll be happy to take any questions.
We do have a question from the virtual audience. It says, they just read an article that ctDNA is less sensitive in picking up lung mets earlier versus other mets. Any input on why this is?
Yeah, that's a great point. So remember, this is a blood assay. So you have to remember there are certain organs that are more likely to shed. This goes back to the seed and soil hypothesis. It is dramatically sensitive for liver metastasis. It is less sensitive for lung metastasis, just based on blood flow. And the true blind spot, if I'm being perfectly honest, is the peritoneum. I have had a case where I was given sort of false reassurance that a patient was NED, when in fact they had a dramatic, unfortunately, case of peritoneal carcinomatosis. So you do have to think, where is it coming from and where am I likely to get shed? So I don't think it's completely insensitive for lung, and indeed, one of the test cases here is when you are trying to follow indeterminate pulmonary nodules. But that is a very, very good observation that the liver is more sensitive than the lung. With that, I think I'm the only thing standing between you guys and breakfast, and I'm acutely aware of that, so I will close, but thank you again for having me.